Hi, I'm Jessica Buscho. You're about to watch a video that I filmed with Colorectal Cancer Alliance about biomarkers. A biomarker is the precise makeup of your tumor that allows your oncologist to target your tumor with specific therapies that could save your life. Filming this video was an amazing experience and my whole family got involved. I really hope that you enjoy it.
Keep your eyes on the horizon and keep moving forward. That's what pioneers do. My name is Jessica. I'm 38 years old. I'm a wife and a proud mom to a Girl Scout, a speedster, and Brennan, my youngest, just built a catapult in our backyard. My husband, Justin, calls me Scrappy.
I do call her Scrappy. She's really scrappy.
Because in cancer, when your back is up against the wall, it's good to always keep looking forward and always be ready for the next move. A person's cancer treatment is a lot like following their own roadmap. Deciding how you navigate that, what route you take, is really up to you and your team. One of the most important things that I tell people is that they need to get their biomarkers tested. Every day we are learning that these little biomarkers make a huge difference in your path forward. Each tumor is unique, and I'm learning about all kinds of things now that have helped me live longer. They're discovering that some of these biomarkers exist in multiple types of cancer, and I could look across and see what research was happening all over the world and how they were making progress, and it could help my disease too. When I first learned about my biomarkers, they were really confusing because it's just a sequence of letters and numbers that make it seem like a foreign language. So that is where forums like Ally to Ally, where peers interact with each other, are important. I feel like the more patients that we can empower by telling them to get their biomarkers tested, the better outcomes people will have. I am a proud 3-time clinical trial participant. Being part of a clinical trial is a lot like being a pioneer, because when the pioneers came out to California, they didn't know what they were going for. They just left where they were and went and hoped that they would find something better. And I have been so fortunate that my biomarker-specific treatment has helped me live so much longer. I know I am alive today because of biomarker testing. When I was given my diagnosis, I was given only 2 years to live, and that was over 4 years ago. I really believe that what happened yesterday doesn't determine today or what will happen tomorrow. I just keep doing my best every single day, keep my eyes on the horizon, and keep going forward.
Hello, and welcome to Personalized Treatment in Colorectal Cancer. I'm Dr. Jennifer Klemp. I'm a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center. My primary clinical and research focus is on cancer genetics and survivorship. I'm very excited to serve as a moderator for this top-tier panel today. We have 2 subject matter experts from the field of GI medical oncology and a resilient survivor who's going to personalize the information presented and put into context as one navigates their treatment and clinical trial shared decision-making through her cancer journey. To start the session, I am pleased to introduce Dr. Kopetz, a professor and deputy chief of GI medical oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. He is also the chair of the NCI Colon Cancer Task Force and leads the Colorectal Cancer Moonshot Program at MD Anderson. Dr. Kopetz, we're excited to hear from you today.
Okay, thank you very much for that kind introduction, and glad to kick off this session. I'll be providing a little bit of a brief overview of tissue-based biomarkers, and then we'll hear from Dr. Lieu about the role of circulating biomarkers. So this is an area that admittedly it's easy to get confused. This is a rapidly changing area. It's an area where even the oncologists need to stay up to date on where things are. And I wanted to just share a very high level kind of what are the biomarkers that we use to personalize therapy? How do we profile the tumor to really understand what therapies are best appropriate? And I'm going to talk about just a few of the ones that are the most common in the field. So I'll do this by showing our best simplified understanding of how cancer cells signal. This idea that the cells communicate through a series of proteins that then lead to their behavior, their growth in the case of cancer. And thinking about really how do we understand these alterations and how these cancer cells differ from the normal cells. So the first one we'll talk about is KRAS, and this is like the grandfather of the biomarkers. It's been around for quite a while, and was really the first one that really defined personalized care in colorectal cancer. And this is acknowledging that there is a mutation in that turns on the KRAS gene, and this KRAS gene then allows signaling to occur, and the tumor can grow. Now, this is independent of any other signaling in the that's going on in the cell, and so the first finding, and where we think about this as a biomarker, is that we recognize that this KRAS mutation results in growth of the cancer cells, even though we may be giving monoclonal antibodies like cetuximab or panitumumab to try to block some of these growth factors. So, so the KRAS mutation is one that absolutely is part of what has to be profiled for tumors. And simplistically, we can look at some of these really early studies, these again from maybe 15 years ago, that showed black and white that patients that had a KRAS mutation in the tumor that were given an EGFR inhibitor like cetuximab had no benefit at all. But when there was no mutation present, those are the patients who derived benefits, the tumor shrank, the cancer was controlled. So we also recognize that now in 2021, we're now starting to develop inhibitors that we can actually now not use this as just a negative selector, but as a way to identify patients who may benefit from a new targeted therapies directly against that KRAS, which is something we really wanted to do. Right now, it's only for the flavor of KRAS, that's the G12C, but I think there's other ones coming. Now, we've also recognized over the years that it's not just KRAS, but it's also NRAS, which is another gene, and we really have to profile both of those in order to better understand who should be treated with various inhibitors. So NRAS, if we're to personify all of these, the KRAS is the godfather, right? But the NRAS is this ignored twin sister, right? The one that is always tagging along with the KRAS, and we have to think about that and profile it. And likewise, NRAS then does not respond to these EGFR inhibitors. Now, increasingly, we're also recognizing it's not just the KRAS and NRAS, but also the location where the cancer cell is that defines how beneficial EGFR inhibition like cetuximab and panitumumab may be. And this is just a figure showing that, the tumors derived in some part of the colon do better or worse than others. We talked about right-sided tumors being the ones that are really here on you can see in the darker red. And it turns out that how you put the sidedness and the KRAS together really helps the oncologist figure out how to sequence things. And this is a complex slide of different guidelines saying, based on sidedness and KRAS status, how should we be utilizing EGFR inhibitors? So these are, key features that we think about. And one of the first things when a patient walks in the door is what is a KRAS and NRAS status, and then where is the tumor, was the original tumor located? Now, there's others. We'll talk about some of these other less common ones and the relevance. The BRAF V600 is this, now we can call it the delinquent young brother. This is the one that is a really aggressive behaving tumor subtype. It has very different behaviors than all the others. But you can see it really is very simply just this next protein down in this cascade that gets mutated and then activated. But it's the context that it occurs. So this one also tells us that EGFR inhibitors don't work, but we've recently found that when you combine a BRAF inhibitor and an EGFR inhibitor, that you can derive benefit. And this is because of this concept of feedback, so that these are all really complex circuits. So when we inhibit one spot, other areas of the cancer cell adapt, and it starts to actually turn on EGFR again and restore signaling. So we actually in the clinic now use a combination of a BRAF inhibitor and an EGFR inhibitor. This is now the standard of care for this subtype. Now, what about others? There's another one, about 4 or 5% of patients. This is the HER2 amplification, the out of control cousin. So this is the one where we have lots of copies of a key growth receptor on the surface of the cell, right? So it has lots of ears looking for signals to grow. And we now have HER2 antibodies, trastuzumab, pertuzumab combination, or trastuzumab and other targeted therapies. Or coming out is a HER2 antibody with a payload, where there's actually a antibody drug conjugate where this payload, this drug, is very precisely delivered to tumors that have a HER2 amplification. Then the final one to think about is this MSI high, or the kind of the crazy uncle that's sowing chaos and mutations. So this is a problem of not having good repair mechanisms in the cancer cell. And as a result, you have many new mutations that are occurring. Many of these don't really do much. They're just mutations that occur. But when there's mutations, and this comes from these deficiencies of mismatch. So you'll hear terms like MSI high or deficient mismatch repair. And these are all synonymous, and we'll use these interchangeably just to be extra confusing. But the beauty is when we have all of these mutations, this helps our immune system figure out that, hey, these cells, these cancer cells, aren't normal, right? These are not normal healthy cells, and it makes it easier for the immune system to target those. And so immunotherapy here is very effective, improves quality of life for patients. You can see that even within a few weeks of getting immunotherapy, quality of life is back to the population norm. And for a proportion of patients, we can actually cure metastatic disease when they're in the setting of MSI. Only about 2 to 3% of colorectal cancer, unfortunately. So how do I use this in clinical practice? We put all these together, the KRAS, NRAS, BRAF, help put it together, the amplification, MSI high, and we can then kind of walk patients through these treatments. And then, the final slide is, who should be tested and when. We really recommend that patients at all stages of disease get testing for MSI. There's hereditary syndromes that play. And then stage 4, you can see some of the ones before. There are some less common ones we didn't get a time to talk about, but I think it's important to kind of understand how these biomarkers are being used by your treating team to help guide the best treatment. Thank you.
So, Dr. Kopetz, that was such a great overview, and I love your kind of description using this modern family where each of the relatives kind of has a role. So, as you kind of went through that overview of how you determine, or the sequence of treatments, do you see a role for repeated testing? So, if someone had their biomarkers run maybe early on in the process, where would they do a repeated biomarker test?
Yeah, so these key biomarkers tend to be ones that are fairly stable throughout treatment. And so we think about if you have a BRAF mutation, you will likely continue to have that mutation, even if the cancer has spread to other areas or if you've received intervening treatment. There are some very rare times where maybe you've received a targeted therapy and it may by the mechanisms of resistance and mutations may have changed slightly. So your oncologist may talk about reprofiling in very selected cases, but in general, these alterations tend to be stable.
Great, that's really helpful. Thank you so much, Dr. Kopetz. So our next speaker is Dr. Lieu, who's an associate professor and director of GI medical oncology at the University of Colorado Cancer Center. He serves as the co-chair of the colon cancer task force alongside Dr. Kopetz. He also serves as the associate director for clinical research. Dr. Lieu, we are excited to hear from you.
Well, thank you for that very kind introduction, and thank you everybody for taking time out of your day to talk about colorectal cancer and personalizing therapy. Today I'm going to talk about circulating tumor DNA, and there's a lot of press and a lot of interest in this topic, and I'm going to specifically talk about the application of this technology, ctDNA or circulating tumor DNA, in the early stage setting for colorectal cancer. We're going to answer the question, is it really ready for prime time? So over the next 9 to 10 minutes, we're going to describe what cell-free DNA is and what circulating tumor DNA is. We're going to talk about how we apply this type of technology in the management of early stage colorectal cancer when somebody has had a surgery to remove all of the cancer and we're wondering if there's any cancer left. We're going to talk about the currently available data. We'll go through this fairly quickly. Regarding ctDNA, we'll talk a little bit about future directions. So a quick primer on what cell-free DNA is and what ctDNA is. So a best way to kind of describe this is that there's a lot of cell-free DNA that is present in our bodies as just a natural consequence of some of the cell turnover that occurs every single day within our cells. If there's a tumor that exists in the body, that tumor can also release other things into the bloodstream, such as a whole tumor cell, these things called exosomes, but also this idea of cell-free DNA. So when tumor cells turn over or actually die, they actually release parts of their DNA into the bloodstream. And we can actually now not only detect that, but actually use that information to sequence the DNA as well. It's important to understand that of all the cell-free DNA that circulates in our body, only a fraction of that DNA would actually be circulating tumor DNA. So a majority of that DNA that actually circulates through the body is actually your own DNA, but in patients that have cancer, a fraction of that may actually be circulating tumor DNA. There are actually two main ways to test circulating tumor DNA, and that is what we call tumor-informed testing, where we actually take the tumor and look for mutations within the actual tumor, and then we could go looking for those same mutations in the body. There's also tumor-naive testing, where we just kind of cast a wide net and look for what we would consider to be traditional tumor mutations. And so we call this like tumor non-informed testing or tumor naive testing. There's some advantages to testing ctDNA, and that is that it's stable. We can actually do some targeted genomic characterization. Some of that actually relates to what Dr. Kopetz just talked to you about some of the mutations or biomarkers that we look at in cancer. But one of the most important things is that this actually gets pretty rapidly cleared by the body. And so when you detect it, you can actually get a real-time look at what is going on inside the body at that moment, as opposed to looking at a tumor that may have been taken out several years ago. There are some disadvantages to ctDNA. One of the ones that we are mainly concerned about is that not all tumors appear to shed detectable ctDNA, and we worry about this with small tumors and sometimes tumors that exist either in the peritoneum, in the abdominal cavity, or if they're small lung metastases. And the results can sometimes be affected by a patient's age as well. So your first take-home point, only a fraction of cell-free DNA is actually circulating tumor DNA in our patients with cancer, but ctDNA may provide a real-time look at what is happening in the body at that moment, and that can be a really, really important thing in terms of how we monitor our patients that have had all of their cancer removed. So what are some of the potential applications of this type of technology? And we're going to talk about this concept of minimal residual disease. And what we really mean by that is that there comes a point when patients have cancer where a tumor gets big enough where we can actually see it on a CT scan and obviously see it during a surgery. But where this kind of technology comes into play is what we call minimal residual disease, where we actually don't see any tumor either visibly or actually be able to detect it on a CT scan, MRI, or even a PET scan. And so this idea is that we may be able to detect cancer before it's visible on a scan, and therefore that gives us an opportunity to, number one, know if cancer still exists, but then number two, see if there's something that we can do about it. And it's really that last point that is kind of up in the air right now. Is there something that we can act on with the information that we get? I just want to show you information from a clinical trial that kind of started all of this off, and this was back in 2016. And we had kind of talked about this idea of tumor-informed testing, and that's exactly what this is. They actually took the tumor out, did a ctDNA, did a mutational analysis of the tumor, and then looked for those mutations in the patient's body. And what we saw, what you see on this graph on the left, is that those patients that after a surgery had no detectable ctDNA. That blue line shows that there is a very, very small percentage of patients that actually have had a recurrence of their cancer. When you look at those patients following your operation that had detectable ctDNA, every single one of them, now granted it's a small number of patients, just 14, but every single one of them had a recurrence. Compare that to the graph that you see on the right, and this is how we kind of traditionally, as doctors, think about high-risk clinical features for stage 2 colon cancer versus low risk, and you can see how much better the ctDNA test performs compared to how we normally determine risk for some of our patients. And so what this graph really shows you is that the predictive value of recurrence for colon cancer was essentially 100% in those patients that had the detectable presence of circulating tumor DNA. If the test was negative, there is no detectable ctDNA, the negative predictive value, a better way of describing that is how well does this test predict who's not going to have recurrence, was around 91%. So not perfect, but still quite good. What about stage 3 colon cancer? Stage 3 colon cancer is a real interesting conundrum in that, we do a one-size-fits-all strategy currently for stage 3 colon cancer, and that is that everybody gets chemotherapy. When we think about what actually happens in these patients, we know that roughly about half of the patients are cured with surgery. So if you take 10 patients with stage 3 colon cancer, half of them get cured by surgery alone and actually didn't need chemotherapy. We know that about 25 to 30% will have a recurrence, and we know that we're giving chemotherapy in that setting almost needlessly because they're going to have a recurrence despite the use of chemotherapy. And we know that about 2 or 3 patients actually get saved by chemotherapy where they don't have a recurrence. So essentially, out of 10 patients with stage 3 colon cancer, we're treating roughly 7 or 8 patients almost needlessly because they either didn't need the chemotherapy or because there's actually, they're going to have recurrence even though we're giving them chemotherapy. And so this test opens up the opportunity to maybe improve or improve our management of stage 3 colon cancer. But some of these studies are really underway, and we really don't truly know what to do with the results of this test quite yet. But the thought is that, boy, could we use a test like ctDNA to maybe not offer chemotherapy to those patients that are already cured and maybe escalate therapy for those patients that are ctDNA positive. But again, we need to do those clinical trials before we start making decisions using this test. Also want to show you that when you test serially, and what we mean by that is we get multiple tests at different points of time, we know that actually improves the accuracy of this test. So if you're ctDNA negative and remain negative, you're going to do really, really well. If you're ctDNA positive and remain positive, the chance of recurrence is incredibly high. And so your second take-home point, the detection of ctDNA post-operatively proves that cancer is still present in the body. And then if you do serial testing, that will increase the accuracy. But again, what we're really going to kind of drive home to end this talk with is we really need to find out how to best use this test in our patients and how we can act on it. So we'll close up with this, the future directions for utilizing ctDNA. Right now, what we know is that the test is incredibly prognostic. What we mean by that is that it can really tell you what's going to happen. The question as doctors and as patients is, well, can we use this test to make treatment decisions? And so how do we improve the outcomes for these patients that are ctDNA positive? We certainly want to make everybody aware that there's some clinical trials ongoing. Dr. Van Morris and Kopetz from MD Anderson are leading this study called COBRA, which is a stage 2 colon cancer study where patients are randomized to receive testing or no testing. But if they do receive testing and a ctDNA test is positive, they will get chemotherapy. This is traditionally not what we do we usually just observe these patients with stage 2 low-risk colon cancer. If they are ctDNA negative, they get standard of care, which is just to observe and surveillance with lab tests and with CT tests. There's going to be a trial coming in the next couple of months for stage 3 colon cancer. And the way this works is that they get a test postoperatively. If there's no ctDNA detected, patients are randomized to surveillance only or chemotherapy. If ctDNA is detected, you get the standard of care chemotherapy or potential escalation of chemotherapy. And I think that these trials will really tell us what to do with this information and if we can really act on it to save lives, which is what we want to do with any test. So the question is it ready for prime time? And I'm actually going to go down to the last bullet point here in terms of the detection of minimal residual disease. And the answer is it is ready for prime time when we're talking about wondering if a cancer is going to come back or not. But the real question that we have to answer here are the results truly actionable? And so we know that this is a very powerful test that has very, very high prediction in terms of whether a cancer is going to come back or maybe the cancer will stay away if the test is positive or negative. Getting multiple tests at different times appears to enhance sensitivity and specificity. And the question is getting this test going to alter clinical practice? And we don't know the answer to that. The question is maybe, or the answer is maybe. Maybe we get increased surveillance. Will it improve overall survival? That's what we want all of our tests to do. We don't know that answer yet. But if we can find a way to get our patients that have recurrence to surgery to remove metastatic tumors, that's a chance to improve overall survival. So I would say right now, the answer is we don't know, but we want to know these answers, and I think clinical trials will help us. And with that, I'm happy to take any questions.
Great. Thank you, Dr. Lieu. I think kind of building on Dr. Kopetz's example of kind of this modern family, I feel like you just described ctDNA as sort of like a teenager. It's out of adolescence, but it's not quite a grown-up. So I kind of like this theme so that, everyone watching kind of gets where we are and that there's some wiggle room there. And through clinical trials, we'll be able to hopefully answer more of these questions.
That's a great way to describe it. Yes. Absolutely.
It's kind of a wiry teenager. But I love that you're trying to figure out how to use that and for shared decision-making. So if you had a patient who had a negative ctDNA after their colorectal surgery, do you think it's worth getting another one, post-operatively, and what would you recommend?
Yeah, so thanks for that question. And the answer is we really don't know. One of the big take-home points that I brought forward in the presentation was that, well, we know that testing at multiple time points does improve the accuracy of the test. If it's negative and stays negative, the chance of recurrence is quite low. If it's negative and then turns positive, or if it's positive and stays positive, we know that the chance of recurrence is quite high. And I think that this is a really individual decision. I've had some patients decide they just want to get that one time point following surgery and that they're done. Some patients really want to use it for monitoring. I think that that's totally fine. And the main reason why I say we don't totally know the answer to that question is really because we don't really know how to act on it quite yet. But I think we will in the coming years. And that's just an individual discussion that you'll have with your physician.
Awesome. Thank you so much, Dr. Lieu. And kind of keeping with our family, we have Jessica Buscho, who is a wonderful 38-year-old, 4.5-year out stage 4 colorectal cancer patient and survivor, who is currently participating in her 4th interventional clinical trial. She is a wife of 15 years, a loving mom to 3 awesome kids, and she is passionate about peer-to-peer connections. I think you will see that from today and her story that she's going to share. She wants to help other patients feel empowered to be able to take an active role in their cancer treatment through learning and parenting with cancer. And I think that is always sort of an amazing balancing act. And Jessica, we look forward to hearing your story. And thank you so much for being here today and sharing with us.
Thank you so much for having me. So I was diagnosed in April 2017. I was only 33 years old at the time. My kids were just 6, 8, and 10. And I was first diagnosed cancer of unknown primary because they found dozens of mets in my lungs on a CT scan, not expecting to see cancer. I was diagnosed in a community cancer center and was treated in a community cancer center to start with. My first year, my disease was really straightforward, like most patients are. I immediately joined Blue Hope Nation and started listening to other patients and paying attention to what patients were having success. And I feel like that really drove me towards trying to learn about my disease. My first oncologist wasn't quite the same optimist that I am, but she did open my eyes to the idea of personalized treatment, because right when I was diagnosed, she tested me for my MSI-MSS status to see if I qualified for a trial. And while I didn't qualify for that trial, it made me start thinking that maybe at some point I would be able to do a treatment that was more personalized to my disease. So while I was having my first 14 rounds of chemotherapy, I was also busy going to visit different doctors who are experts within my insurance network. And then I also took the time to go see an expert at an NCI center, which was great and gave me peace of mind that we were on the right path. And fortunately, after those first 14 rounds, at the end of my first year, I qualified for surgery to remove my primary tumor. And we were able to follow that with a nice long period of watch and wait. So here is me at my very first round of chemotherapy back in 2017. So in my second and third years, it was really defined by first a period of watch and wait, which is where we just wanted to find out how my cancer would act. And then about 8 months after my surgery, my tumor started growing a little bit in my lungs. So I resumed my original chemotherapy. At that time, one of my oncologists suggested biomarker testing, which was a brand new thing, but my insurance denied it and I didn't know anything about it. So we just moved on. But in January 2019, about a year after my initial surgery, I was volunteering at a Colorectal Cancer Alliance booth at ASCO GI, and which is a huge oncology conference. And someone from a liquid biopsy company came by and said, "Hey, have you had your biomarkers tested?" And I was like, "Oh, I don't know. I don't know what they are." And he said, "They're starting to find out that some of them might be actionable. You should really have it tested." And that conversation probably changed my path and maybe possibly saved my life. So after that conversation, I went back to my oncologist and said, I really do want to have my biomarkers tested. So we completed an appeals process and we even applied for financial aid, which a lot of patients don't know exists with some of these biomarker tests. And we were able to find out what biomarkers I had. And initially, I was totally overwhelmed. When you first get your results, it's like letters and numbers and you don't know what they mean. And a lot of them sound the same and you don't know how to pronounce them. And so I just went back to, I'm going to share the picture of volunteering. So I went back to my patient friends online and started searching for people in the online communities for people who had the same mutations to connect with them and find out what they were doing. Blue Hope Nation was so helpful during this. And I met other patients who had the same mutation as me, and everyone was talking about the same thing. Our mutation was the one that they thought might be actionable. So I realized that it would be really helpful for me to find and get an opinion from an expert in my exact mutation. So in May 2019, I hopped on a plane, and in one day, I went to 2 different cancer centers to meet 2 different experts on my mutation and find out about the trials that they were going to be opening for my mutation. At the same time, I had just developed a pretty severe allergy to oxaliplatin, so we were on a total time crunch, and it was like we needed to find out what my next step would be. So there weren't any spots at the moment, so it was about summertime. We decided to just go ahead with our plans, which was to go on this awesome road trip. And we went to 20 national parks as a family, over 20, and drove all over the Western United States and just had an awesome summer, hoping that by the time that we got back that something would be open. Unfortunately, nothing quite opened yet. So I came back home and started Full Fury as second-line chemotherapy. And we were really optimistic about Full Fury working, but I failed it after just 8 rounds, which was a surprise, but I'm learning now that this is increasingly common. So really this would have broken me, like it really would have broken my spirit, but I had become so increasingly optimistic about this sort of specific personalized treatment. And I had recently had a test that revealed I had a moderately high TMB, so there was some optimism around possibly being able to try immunotherapy. So I met with an expert in that, just like I had met with a different expert before, and decided to enroll in an immunotherapy clinical trial. So that was my very first clinical trial. I was really proud and excited to be part of it and to hopefully be part of the forward momentum that would help other patients. But just a few months after that, as we all know, in March 2020, the world came to a screeching halt. So luckily, I was able to continue on my trial as this was going on. I had to go alone, which is a little nervous, but we kept going. And things were looking pretty good in my lungs. But then in May 2020, we found out that I had developed brain mets. My team here was so awesome, immediately had surgery and Gamma Knife to take care of the brain mets. But my outlook for systemic therapy was not good because I was kicked off my trial and we didn't know what steps we would do next. So from my hospital bed in the neuro ICU, I started emailing every single oncologist I had met and reaching out back to all those same patients that I had met over the 3 years before that. And I was so lucky to find out that a trial spot had opened up at one of the sites that I had visited before. So I was really excited about it. The only caveat was that it was about 375 miles from our house. So we decided to reach out to family and friends. We reached out to our local newspaper, and with the help of 300 donors, we were able to purchase an RV. And this is me participating in the trial that we used to travel to treatment. And that treatment actually shrunk my tumors by 40% and qualified me for localized treatment of my lung tumors, which was nothing short of miraculous after the year we had had. So just this year, as I continued on my first trial and then eventually moved on to my second trial with the same team, my doctor was a huge advocate for repeat biomarker testing, as we just heard about, because my trial is biomarker specific. So we wanted to sort of stay on that same path. So I had repeated tests, and these drugs some targeted drugs are not cytotoxic, so they only affect the cancer cells, which means you can have other therapies while you're on it. So like I said, while I was on the trial, I was able to have my lung spots ablated with the permission from the sponsor, which really made a big difference in my outcome also. These drugs are still new and we're learning a lot, but what I have discovered and keeps me really hopeful is that a lot of these mutations occur in multiple types of cancer. And because of that, we're starting to see collaborations across cancer types, which really just helps because we all know how underfunded colorectal cancer research is. So it's great when we can collaborate with other cancer types. So I am currently on my fourth trial, and it's not quite as far as the other ones, but we're still traveling in this great RV. You can see my kids here. And these are my take home tips for patients. The number one thing is get to know your disease. Ask for more testing, and knowledge is golden. Some patients feel like they're going to feel overwhelmed if they find out something that might be possibly have a negative connotation, but not knowing won't change it. So the more you know, the better. And even if you're not interested in trials, this testing can be helpful because some of it informs standard of care treatment, like Dr. Kopetz mentioned earlier, or off-label use of treatments from other cancer types, like I mentioned, biomarker-specific medications, and then get a second opinion with an appropriate expert, so an expert specific to whatever the characteristics of your disease are. Seek out the help of family or friends. Use reliable information sources and resources. So if you have a person in your life who loves to do research or who loves science, this might be the time to say, hey, you know how you always wanted to help me? Now's the moment. So, and also CCA has some great resources. They also have for stage, I believe it's 3 and 4 patients, they have a service that you can use that can help match you with trials and help you interpret your results. And then really important, look up the acronyms for words you don't know. Don't just glaze past it. It's really important to try and understand things. And probably my biggest piece of advice is to connect with other patients who share your disease similarities and know the power of community. Really listen to people, look for the people who are living for a long time, Never stop asking questions and really listen for understanding. And then when you're on the online forums, whether it's Ally to Ally or Blue Hope Nation, access them from my computer because the search features are much more useful. That's my secret tip. And then the final thing, which is people always say I'm so optimistic, and this is why: science is never standing still. Optimism rooted in knowledge of forward momentum is so powerful. And I just always keep my eye on the horizon, and I know that great things are coming.
Thank you, Jessica. And I know you were nervous to share your story, but you did a great job. And I think you gave, I love the analogy of your cancer journey with your 20, tour national park with your family, because those are very analogous, right? You went to, there's lots of different places, there's lots of different things you need to seek out. And I want to just thank you again for sharing that very powerful story. So you gave some great tidbits here for patients. If you were recommending a patient look for information on biomarkers, what's kind of your one go-to that you would recommend to better understand, and as you said, kind of understand what each of the acronyms mean and so forth? What's your go-to?
I really can't emphasize enough the power of peer-to-peer support, because all the online resources that are out there are really great, but hearing it from someone who understands it, who has been through it, who understands what the implications of a certain biomarker might be in their care or in their treatment, and hearing how it might affect them really makes a big difference. So getting connected to your peers makes all the difference in the world.
Great. And there's great resources, obviously, from the Colon Cancer Alliance and others that you've mentioned. So I want to ask Dr. Kopetz and Dr. Lieu to join us again and thank this panel, who really is top tier, top notch, and see if there's any final thoughts that anyone has as we close this session.
I mean, I think as Jessica shared, is just knowledge is so important, and I think trying to find that right balance of being informed about your cancer, but also recognizing this cancer is so complex, and so allow yourself the acknowledge that you're going to dive in and you may feel a little overwhelmed, and that's all right. There's great resources, community out there to help you understand and help digest this information, but it can be very daunting. But I think that doesn't mean that it's not worth the effort in the end.
Yeah, I think that's really well said. And I would just to add on to that is that, when you think about 2007, 2008, it was a completely a one size fits all strategy for every single patient. And it's really remarkable, how far we've come, but we need to obviously do so much more. We want to empower our patients to ask these questions, ask about biomarkers, ask how that might, personalize your own therapy, and have that discussion with your team. And know that having that conversation can really get you to where you obviously want to be, and that is to the best treatment possible. And Jessica, obviously, thank you so much for sharing your story. Really, really remarkable, and thank you. You did a wonderful job.
Well, I think Dr. Lieu kind of summarized the title of this session today: Personalized Treatment for Colorectal Cancer, which is so true. There is not a one size fits all anymore, and really important to gain that knowledge, gain the power, and be part of the process. So thank you to all of you today. Thank you to our panel, and enjoy the rest of the conference. And thank you to the Colon Cancer Alliance.